Thank you very much for inviting me to present at the PLM business meeting a short lecture related to circulating tumor DNA as a cancer biomarker. I will take this opportunity to also mention some ways of contesting literature reports for the benefits of our younger colleagues. As many of you know, the scientific literature is full of inaccurate publications, and the question arises as to who and under what circumstances should challenge these erroneous results. I advise the young colleagues that if they decide to challenge, they should be civil and generous with the publications, be very careful, be confident on what they say, because if they are wrong, they will pay a heavy price. But if correct, they will be rewarded. And I mentioned here for your information that over the years of challenging a number of important papers in the literature, some of these papers were the most highly cited among all the papers that I published. Most of our challenges were against giants, either journals or investigators or companies, but like David and Goliath, in all cases we were able to win the contest and the discussion. The outcomes were confirmatory of our original findings. In these slides you will see some of our most famous challenges starting in the year 2002 with a paper published by famous pathologist Lance Liotta, who was credited with the discovery of the laser capture microdissection on a method that he published in Lancet regarding ovarian cancer diagnostics. We challenged this data very early, and after 10 years of deliberations, it was proven that our challenge and our criticisms were correct. We also challenged the famous proteomics investigator at Sloan Kettering Cancer Center, Paul Temst, in the year 2006 on a different paper on cancer diagnostic published in the Journal of Clinical Investigation. We also challenged Johns Hopkins investigator and leader Robert Getzenberg in cancer research on cancer diagnostics, and we have proven to be correct. I'm sure many of you are familiar with the Theranos story, which we challenged in the year 2015 onwards with a number of papers, and now the outcome of the Theranos story is out. The Theranos company is bankrupt, and the chief executive of Theranos is now under trial for fraud and possible imprisonment. In the year 2015, we also challenged another diagnostic method published in Cancer Cell. In year 2018, we challenged the circulating tumor DNA as a cancer diagnostic for early cancer detection published in Cell. Be careful here that, as you will see from my presentation, we sponsor the application of circulating tumor DNA in various applications, but we do not sponsor it for general population screening, as you will see the reasons in the presentation. More recently, we challenged Dr. Leroy Hood, a famous scientist who originated a company called Arivale on wellness testing. We published papers back to back on point counterpoint, and the result came out in 2020 that Arivale went to bankruptcy. I will now move on with the presentation on circulating tumor DNA as a cancer biomarker. For this presentation, I declare no conflict of interest. Circulating free DNA was initially discovered by clinical chemist Dennis Law in the 1990s, who found that in the serum of pregnant women there is 5 to 10% DNA of fetal origin. As you know, this discovery has led to the application of circulating free DNA for the non-invasive detection of trisomies in fetuses by using maternal blood. Later, Dennis Law and others have identified cell-free DNA in the serum of patients with cancer. They then thought that they will design something known as liquid biopsy for diagnosis and prognosis of cancer. Liquid biopsy involves obtaining blood or other fluids and then analyzing them, usually by molecular techniques. Liquid biopsy is minimally invasive. It can analyze circulating tumor DNA, tumor cells, exosomes, and other components. As you can see from the slide, peripheral blood is the preferred site for the liquid biopsy by obtaining a tube of blood. But other fluids, such as cerebrospinal fluid, saliva, synovial fluid, ascites fluid, stool, and urine, can also be used with equal success. One would wonder, what is the definition of circulating tumor DNA? Circulating tumor DNA is DNA originating from cancer cells that has been shed into the bloodstream, and you should remember that the amount of circulating tumor DNA is proportional to tumor size. It is also important to note that healthy cells also release what is known as cell-free DNA into the circulation. If you extract circulating free DNA from normal people, you will usually find about 1 to 10 nanograms of DNA. In this slide, we show how the liquid biopsy is performed. Usually, a tube of blood is obtained and DNA is extracted. This DNA can then be used for analysis by using various techniques, including whole genome sequencing, whole exome sequencing, targeted sequencing, or by looking for gene fusions, copy number alterations, and DNA methylation status. When performing liquid biopsies, it is very important to understand how this works. An important caveat is that blood contains both normal DNA originating from normal tissues and genetically altered DNA that originates from cancer cells. Genetic analysis could discriminate between the normal DNA and the cancerous DNA by using for mutations, epigenetic changes, and other molecular changes. The ratio of cancer to normal DNA as a percent is importantly known as mutant allele fraction. We know that the higher the tumor volume, the higher the mutant allele fraction, and the easier the analysis. We should remember that when the mutant allele fraction is very low, such as less than 0.1%, we need special techniques to analyze the circulating tumor DNA, which is present in minority in comparison to normal DNA. Let us now show some clinical applications of circulating tumor DNA. Circulating tumor DNA is an excellent prognostic factor for cancer. For example, in a 2016 study of 230 stage 2 colon cancer patients, 100% of those who had detectable circulating tumor DNA right after the surgery relapsed, but more than 90% of those who were negative for circulating tumor DNA did not relapse. This shows that circulating tumor DNA carries very important prognostic information for cancer. Like other tumor markers, circulating tumor DNA can also be used to monitor the progression of the disease And this is an example with breast cancer who has been treated at various occasions with ebirubicin, letrozole, and ebirubicin. And you can see here the blue line represents the circulating tumor DNA, which goes down with the treatment and then goes up with relapse. In comparison to CA15.3, the classical breast cancer biomarker, and circulating tumor cells. And you can appreciate here that the circulating tumor DNA is actually a superior monitoring tool in patients with breast and other cancers. A very important application of circulating tumor DNA involves the monitoring the success of treatment. As you can see here, a patient is treated initially with such certain therapy, while is monitored by liquid biopsy for mutations and the intensity of the mutations in circulating tumor DNA. In this case, the circulating tumor DNA analysis shows that the mutations have been reduced and the intensity has been reduced, thus indicating that the therapy is working and should continue. On the other hand, for this patient, you can see that there is progression because the intensity and number of mutations is increased, thus alerting the clinicians to select a new therapy. A very important application of circulating tumor DNA. The amount of circulating tumor DNA in the circulation, as I mentioned earlier, correlates quite well with the size of the tumor. And you can see here that larger amounts of circulating tumor DNA are correlating with larger tumors, advanced tumors, or later stage tumors. While the utility of circulating tumor DNA for monitoring success of treatment and for prognosis is unquestionable, there is a debate in the literature if circulating tumor DNA can be used for the big application of early cancer detection. Many of you have probably heard of a company called Grail, which invested billions of dollars in using circulating tumor DNA for early cancer detection. Grail is embarking on a very big project aiming to enroll 10,000 individuals with cancer and 3,000 healthy individuals and analyze their circulating DNA to find differences between the cancer and the non-cancer, thus developing methods for early cancer detection. The techniques that Grail uses to analyze circulating tumor DNA include targeted sequencing of about 500 genes previously associated with cancer, using whole genome sequencing and copy number variations, whole genome bisulfite sequencing to study methylation status, and also using DNA fragmentation to study the sizes of circulating tumor DNA. Academic investigators have also published on detection of early cancer by using circulating tumor DNA, such as the one paper shown here. In this paper, the authors claim sensitivities for detecting cancer in the area of 50 to 60% at 95% specificity, which are good numbers if they can. Unfortunately, these and other studies suffer from the drawbacks that these investigators have used clinically detected cancers with relatively high mutant allele fraction of 0.1 to 1%, as is shown in the figure. Another approach used by my friend Nicholas Papadopoulos includes combination of circulating tumor DNA with classical biomarkers for early detection of cancer. These authors also claim sensitivities between 70 and 90% at 98% specificity, which are good numbers if they can be. Based on this paper, Nicholas managed to develop a company called Thrive, and attracted $110 million in investment to develop this as a. I draw your attention here that my group, as you can see from this publication in BMC Medicine, has raised doubts about using circulating tumor DNA for early cancer detection. Our rationale is very simple. We asked the question if there is enough circulating tumor DNA from small tumors to make a reliable. This slide summarizes our calculations that the tumor of 27 millimeters in diameter can yield about 6 genome copies in the circulation with a tube of blood, thus likely being able to make the detection possible. However, as the tumor gets smaller to about 6 millimeters in diameter, the mutant allele fraction is so low that you cannot retrieve even a single genome for molecular analysis, thus making the diagnosis impossible. Here I draw your attention briefly that not only the sensitivity of a cancer test is important, but also the specificity. And it is now well known that mutations can be found in circulating free DNA from normal people, especially due to a precancerous condition called clonal hematopoiesis. I conclude this presentation by mentioning that if an asymptomatic individual undergoes cancer screening, it is possible that you get a true positive, which is what you want, but it is also possible that you get a false positive, and these false positives can lead to unnecessary interventions for the patient. We predict that the results of many tests will be equivocal without any true conclusion. It could be also false negative, thus reassuring people that they don't have cancer when they actually do. I close this presentation by thanking my students Claire Fiala, Annie Ren, Dorsa, Sohai, and Kaidli Di Paolo for helping me with preparing this presentation.